Hello there, it's Luke. We've got another tutorial coming up here and I'm just about to appear in the top corner of your screen. Hi. So we're going to be thinking about cardiac output and blood pressure and the various factors that will impact on those. And the idea of this session is to give you a framework for understanding the normal physiology and the different ways that homeostasis is maintaining your blood pressure and hence your perfusion of your sort of vital tissues, how different elements might contribute to a drop in your blood pressure or your cardiac output during pathology and say a shock process, and also give you a bit of an idea about the different elements that we can manipulate with our therapeutic interventions when we are confronted with a patient that may be shocked and perhaps not perfused as best they might be. The third sort of thing that we're going to focus on is to think about how actually some of these even physiological changes might impact upon the sort of condition of the heart muscle tissue itself. Okay, so I'm going to disappear and we'll get on with the PowerPoint presentation. So here's three terms that you may already be familiar with: stroke volume, the volume of blood that's ejected from the left ventricle during a single systole; heart rate, which is the number of contractions per minute; and then cardiac output, which is the total amount of blood that's ejected from the left ventricle during a minute. And we can see that the relationship between those things is fairly straightforward. Cardiac output equals stroke volume times the heart rate. That makes sense. So we're going to look at these in a bit more detail just now. And stroke volume is really made up of contractility and preload. So what do we mean by those terms? Well, contractility is the force generated by the rapid contraction of the heart muscle cells all working together to squeeze the blood from the left ventricle. And I'm going to demonstrate to you the difference that perhaps contractility can make. We're going to look at an echocardiogram. So I've got my cursor here, and the thing that I want you to focus on is the left ventricle. So if you orientate yourself, here's the apex up here, here's the mitral valve. We've got the septal wall of the left ventricle, the free wall of the left ventricle, and then, like I say, the mitral valve is sat down here. So here are our two echocardiograms, and you can see the one on the left is beating much better. So look, as the two walls are sort of coming together. The septal wall, the free wall, they're moving together, and the annulus, the mitral valve, is moving towards the apex. And this might be ejecting anywhere between, say, about 50 and 70% of the end diastolic volume within the left ventricle. Now, if we contrast that with this one on the right-hand side, we can see that neither of these walls are moving particularly well. There's barely any movement towards the apex down here. This is a really poorly functioning, failing heart that might only be injecting, say, about 20% of the volume within the left ventricle. Now, preload, that refers to the tension generated by stretching the cardiac muscle fibres, and essentially the more stretched they are, the more contractile, the more force can be generated when systole occurs. And a way of thinking about this might be to consider an elastic band. So anybody that's flicked an elastic band across the room will know that the more tension, the more you pull and stretch that elastic, when you let go, the further it will go, the more energy it will shoot off with. Okay, and this was described by Frank-Starling, what we call the Frank-Starling curve or Frank-Starling relationship, and they found that if you look along the x-axis down here, the more full the left ventricle is at the end of diastole, so when it's been filling, the greater the tension on the walls of the heart muscle, therefore the greater force of contraction and also the greater stroke volume that's ejected. However, there is a point at which the left ventricle can be overfilled and overstretched and ceases to contract as efficiently, and especially in a failing heart like the image that we just saw on the echocardiogram, that can occur quite easily, especially in clinical practice if we give somebody too much fluid and have a failing heart. So we're going to think about heart rate just now, and it's fairly intuitive to think that actually if you look down these here, you can see that as we increase the heart rate, the cardiac output goes up. However, that only works to a point, and so if you have an extreme tachycardia, and this is a supraventricular tachycardia of about 200 beats a minute, we know that the ventricles fill during diastole. So when the heart muscle is relaxed, that's when the blood flows into the left ventricle. However, if your heart rate is going so fast, then there is less time to fill that ventricle. So it means there's less preload, those myocytes are being stretched less, so you're getting a lesser contractility, less force of contraction, and a reduced stroke volume. And so we might think about this as a decrease in stroke volume because the ventricles are less full is caused by the extreme tachycardia, and that will give us a reduced cardiac output. So that's our first relationship to consider. We then move on to blood pressure, which is equal to cardiac output, which we've just discussed, and systemic vascular resistance, which we're about to discuss. Now, when I talk about blood pressure, what we really, the end point of it all really is to have your tissues perfused with oxygenated, nutrient-rich blood, and for the toxins and the carbon dioxide to be taken away. Now, blood pressure happens to be the thing that we can measure easily in practice, but also the flow and therefore the perfusion of those tissues is affected by the blood pressure, in the sense that the blood will flow from an area of high pressure to an area of low pressure. So the arterial end of a capillary bed needs to have a greater pressure than the capillary bed and the venous end of that tissue. So that's why blood pressure is important. So thinking about systemic vascular resistance, what's that? Well, you'll recall from your anatomy and physiology that your blood vessels, the sort of innermost layer, that medial layer, the tunica media, is made up of smooth muscle cells rather. And the upshot of that, so here's another representation of a blood vessel in cross section, is that if those blood vessels are relaxed, we get something called vasodilation. And when the lumen, so when the hole in the middle of the blood vessel is enlarged because those muscles are relaxed, there's less resistance to flow. And in terms of our systemic vasculature, in terms of our arterioles that lead to whichever organ or tissue, that means that the blood more easily flows to the peripheries, to places like the gut and the stomach, and these large veins that we have in our legs that we refer to as capacitance vessels, which act as sort of reservoirs for blood for when we may need to sort of use it. At the other end of things, if the cells within the smooth muscle layer, the tunica media of the arterioles in particular, contract, this causes vasoconstriction, and that lumen through which the blood flows is much smaller, and so it's a resistance to blood flowing through those vessels. Now, again, this is happening sort of all over the body at sort of to different degrees. However, if we get an increase sort of globally, if you like, of all of many of the blood vessels acting together to squeeze the blood away from the peripheries, away from those capacitance vessels, clearly you can see that there'll be an increase in blood flow towards the heart, what we call venous return. And if there's more blood flow towards the heart, that means there's more blood flow into that left ventricle, which is greater preload, greater contractility, and it will improve both our cardiac output and our blood pressure. And we're just restating that here. So squeezing the blood away from the peripheries will give us a better venous return and will increase our preload, which is a good thing. However, that comes at a cost. And afterload, which is the pressure within the systemic circulation, and that's the pressure which the left ventricle must overcome in order to open the aortic valve and eject the oxygenated blood into the systemic circulation. That afterload will increase if the systemic vascular resistance increases. Now, if we think for a moment about myocardial perfusion and look at this diagram, so we can see we've got the aorta here and the coronary vessels which actually perfuse the myocardium arise from the aorta. And there are two things that we need to consider about that. One is that blood flow to the myocardium occurs during diastole. So when the heart is at rest, then blood flow can head towards the myocardium and actually perfuse the heart muscle itself. If the systemic vascular resistance is increased, that means the pressure within the aorta is increased. And as we've already said, that blood will flow from an area of high pressure to low pressure. So if the pressure within the aorta is increased, that means there's likely to be better flow through these coronary vessels to the myocardium itself. So just to recap, if we have an increase in heart rate, there will be an increase in cardiac output, but also an increase in demand for oxygenated blood. Similarly, there will be less time for that oxygenated blood to travel through the coronary arteries and actually perfuse those myocardial cells. So an increase in heart rate comes at a cost. In terms of systemic vascular resistance, if that is increased, then yes, there will be an increase in venous return to the heart, which is good because of improved preload. But it will also mean that there will be a greater pressure against which the left ventricle has to contract to open the aortic valve and to eject the blood into the systemic circulation. But an increase in systemic vascular resistance will mean there's more pressure within the aorta, a greater pressure differential between the aorta and the relaxed myocardial muscle, and so the blood flow will flow more freely through the coronary vessels and perfuse the myocardium better. So these are our two formulae that we've just touched upon, and you can see that cardiac output appears in both of them, so we can switch things around and say that blood pressure is equal to stroke volume times the heart rate times the systemic vascular resistance. Now this will be helpful in order for us to pick apart and understand the physiological processes like the baroreceptor reflex and the renin-angiotensin-aldosterone system that help maintain homeostasis and blood pressure and therefore tissue perfusion, but also it can be used to sort of think through what's happening with our shocked patients, and also if we choose to give any therapies, which therapy might be the best one if we're thinking in terms of improving things like preload, stroke volume, or the systemic vascular resistance to do all of those things. So in summary, we can see that blood flow and tissue perfusion are dependent on an adequate blood pressure. Cardiac output is related to the stroke volume and heart rate. Similarly, blood pressure requires an adequate cardiac output and systemic vascular resistance to the right degree. Increasing any of these variables will improve blood pressure to a point. However, only to a point, and also increasing any of these things may compromise the myocardial perfusion itself and actually worsen a pathological process if that's what's occurring. Thank you very much for your time. That's the end of the tutorial. Thank you.